Hello and welcome to Learn from the Case. How are you? In this video, we continue talking about migraine. This is the fourth video of 5. I'm going to talk about migraine treatments. The choice of different types of treatments is based on multiple factors that are specific to each case and each patient, the health history, and so on. But assuming that a mostly healthy person has migraine and does not take other medications, neither is pregnant or breastfeeding, etc., one of the things to take into account when choosing the treatment is to know if the migraine is acute or chronic in onset. Emergency or abortive treatment. Acute treatment is aimed at stopping the development of headaches. In the first line of treatment, we count with non-steroidal anti-inflammatory drugs. It is considered effective in many cases and should be taken quickly when the headaches start and with a single large dose. Non-steroidal anti-inflammatory drugs like ibuprofen 500 mg to 600 mg or naproxen up to 800 mg or diclofenac up to 75 mg or aspirin or acetaminophen, which is called also paracetamol. Here, each patient will find the type of non-steroidal anti-inflammatory drugs that best suit that specific patient in terms of effectiveness and considering other medication or conditions. For example, a patient who drinks a lot of alcohol, perhaps a patient who is trying to quit but still consumes alcohol regularly, should perhaps take iprem and not paracetamol, which is called also acetaminophen. While a patient with diabetic nephropathy should perhaps opt for paracetamol and not ibuprofen. Non-steroidal anti-inflammatory drugs are in general effective in mild to moderate attacks without nausea or vomiting. If a non-steroidal anti-inflammatory drug is not effective, another class of medication should be used. For example, triptans, which is the first line in patients with allodynia, which means pain due to a stimulus that normally does not cause pain. For instance, sumatriptan, given as subcutaneous injection 6 mg or nasal spray 20 to 40 mg or nasal powder 10 to 30 milligrams for 24 hours, or orally 50 to 100 milligrams once a day, or solmitriptan 10 milligrams every 24 hours, nasal 2.5 to 5 milligrams in a single dose. Triptans can be used with or without a non-steroidal anti-inflammatory drugs, for example, naproxen, for moderate to severe attacks. Patients who do not respond well to one triptan may respond to another. Triptans should be limited to less than 10 days of use within a month to avoid rebound headaches or medication overuse headaches. Triptans are serotonin receptor subtype selective drugs. Due to the activation of 5-hydroxytryptamine 1B and 5-hydroxytryptamine 1D receptors in the coronary arteries and cerebral vessels, there are recommendations against its use in patients with ischemic stroke, ischemic heart disease, poorly controlled hypertension, angina, pregnancy, hemiplegic, or basilar migraine. In these patients, with cardiovascular risk, the most appropriate drug seemed to be a selective serotonin 1F receptor agonist that does not cause vasoconstriction. For example, lasmiditan is a central penetrating agonist of the 5-hydroxytryptamine 1F receptor with high affinity, but more studies are needed. Furthermore, the exact mechanism of action is unknown, but the therapeutic effect of lasmiditan in the treatment of migraine probably involve agonist effect on the 5-hydroxytryptamine 1F receptor, reduce release of neuropeptides, and inhibition of pain pathways, including the trigeminal nerve. I do not have experience using this medication as it is not available where I work, but there are recent promising studies regarding the use of this medication in migraine patients. In US, the Food and Drugs Administration approved lasmiditan oral tablets, Ribon, in October 2019 for the acute treatment of migraine in adults. The initial dose of lasmiditan is 50 to 100 mg, particularly effective in patients who cannot use triptans due to cardiovascular risk. The dose can be increased to 100 or 200 milligrams, but no more than one dose should be taken in 24 hours. A major side effect of lasmiditan is dizziness. Therefore, patients should not engage in potentially hazardous activities or drive a motor vehicle for at least 8 hours after each dose of lasmiditan. Lasmiditan is actually an antidepressant and has interaction that must be taken into account, especially with similar drugs. For example, selective serotonin reuptake inhibitors or selective serotonin and norepinephrine reuptake inhibitors due to the risk of serotonin syndrome. Combining non-steroidal anti-inflammatory drugs with a triptan appears more effective than using either drugs class alone. Antiemetics: metoclopramide, chlorpromazine, and prochlorperazine are typically used as adjunctive therapy with non-steroidal anti-inflammatory drugs or triptans to reduce nausea and vomiting. Diphenhydramine can also be added to prevent dystonic reactions that can be caused by metoclopramide mainly. Ergotamine is the first pure ergot alkaloid to be isolated. This was in the year 1920. It is a precursor to LSD, lysergic acid diethylamine. Ergotamine has not yet demonstrated any particular effectiveness and can produce significant side effects, including cerebrovascular, cardiovascular, and peripheral ischemic complications. It has been proposed that it works by preventing blood vessels in the head from dilating, vasodilatation, and causing headaches. But beyond that, it is not known why it relieves migraine. But ergotamine and dihydroergotamine, intravenous and intramuscular, subcutaneous, and intranasal, are recommended for acute attacks as parenteral administration and are effective as adjunctive therapy for medication overuse headaches and migraine state. Dexamethasone 4 mg can be used to reduce post-discharge headache when given to people with acute migraine on metoclopramide. It might reduce early recurrent headache but does not provide immediate relief. However, corticosteroids should be used with caution in patients with migraine, as corticosteroids can cause fluid retention. It can also raise blood sugar and blood pressure. Many times, one of these medicines that I mentioned comes with caffeine. The main reason is that caffeine increases the absorption and strength of the medication to provide faster relief. Otherwise, in general, patients with migraine are encouraged not to consume caffeine because for some of them it can be a migraine trigger. There are patients who might be candidates for preventive treatment. For example, people with frequent or prolonged headaches, attacks that cause significant disability and reduced quality of life, contraindication or failure of acute therapies, significant negative effects of abortive treatments, risk of overuse of headache medications, menstrual migraine, along with short-time premenstrual prophylaxis, hemiplegic migraine, migraine with brainstem aura, persistent aura without stroke, migraine infarction. Preventive treatments are the following. For instance, beta blockers, metoprolol and propranolol, especially in hypertensive and non-smoking patients. Antidepressants, amitriptyline and venlafaxine, especially in patients with depression or anxiety and insomnia disorders. Anticonvulsants, valproic acid and topiramate, especially in epileptic patients. Calcium channel blockers, verapamil and flunarizine, especially in women with childbearing age or patients with Raynaud's phenomenon. Peptide antagonists related to the calcitonin gene, for instance, rimeshpan, erenumab, or fremanezumab. Third-hand alternative, and in Sweden only for patients with at least 2 migraine attacks per month and who, after optimized treatment, did not have an effect or tolerated at least 2 different medicines against their migraine attacks and tried with 3 times. Alternative treatment, hear me out here. Don't ignore these tips you can do yourself to improve migraines. Many people hear this and take it to heart and get many positive results. Some become so good that they don't even need to use any medication after successfully incorporating a good combination of these lifestyle changes into their life. There is much a person can do to improve their own health. Lifestyle changes to healthier routines, regular exercise, yoga, relaxation training, cognitive behavioral therapy, biofeedback, trigger reduction. Migraine triggers should be documented by each individual to reduce them in the future. This is another thing that must be taken into consideration. Identifying and avoiding triggers, which are different for each person. Other treatments, we can mention transcutaneous stimulation of the supraorbital nerve that may reduce the intensity of a headache. Transcranial magnetic stimulation, effective as a second-line treatment without serious side effects. It might also be offered as an option to treat chronic migraine. But be careful, it is contraindicated in patients with epilepsy. Also, acupuncture, among others. But these treatments are not always subsidized by the health area and are not supported by studies. There are people who are very satisfied, and on the other hand, those who do not give a cent for the effect. So I'm not recommending them. I'm just reporting what's out there. Peripheral nerve block, occipital nerve block, supraorbital and supratracheal nerve block, sphenopalatine ganglion block can also be tried. Local anesthetic is injected. It's not Botox. There is also Botox treatment, which is not the same. In the latter, Botox is applied to the muscles, so that releases the regions where it is injected. Botox causes relief in chronic migraines by relaxing the muscles to react to migraines. But it does not work in all cases. It is individual. And with this last thing, I say goodbye today. As always, you are welcome to leave me your comments or questions. Thank you for your attention and be very, very well.